Hello everyone, it's Dr. Locklear here, and I'm coming to you with Exemplar 12E, which is thyroid disease, and that falls under the concept of metabolism. And so when we have issues with our thyroid, we can have all kinds of problems, and there's two different types of thyroid situations that you can have, and we're going to look at those. So let's get started. So we're going to look at the pathophysiology of thyroid disease. What's happening, in the endocrine system? Why does this fall under metabolism? And so we're going to look at how it occurs, what causes it, what's the etiology, what are the risk factors, and how do we prevent it? And thyroid disease really cannot be prevented because it is a genetic disorder. Identify the clinical manifestations of thyroid disease. So what are the symptoms you will see? And I'm really going to focus on hyper and hypothyroidism in this chapter, so I may skip a few things and tell you to read it on your own, okay? We're going to look at the diagnostic test and how do we collaborate care, and we're going to look at the lifespan and what age group is usually affected, and we're going to apply the nursing process again here with this disorder assessment, really doing a good observation, looking for specific symptoms that we will talk about. So what is the overview? The thyroid gland is a small saddle-shaped gland that wraps around the anterior portion of the trachea, as you can see in the picture here. Altered production or use of TH, and this is the thyroid hormone, affects all major organs. So your thyroid hormones affect all the organs in the body. And if it is untreated, it can result in cardiac disease and you can die from this. In the adult, the thyroid hormone changes primarily affect metabolism, so they affect our ability to burn up calories. So you'll see with people with hyperthyroidism, they tend to be thin, they lose weight, they have a rapid metabolism. People with hypothyroidism have a slow metabolism and they tend to gain weight with the disease. And so it primarily affects cardiovascular, gastrointestinal, and neuromuscular function. Thyroid disorders are among the most common endocrine disorders, and if left untreated, can result in cardiac disease and ultimately death. And it's not uncommon for a person that has diabetes to have thyroid problems as well, because they're both in the endocrine system and they both affect metabolism. So what is hyperthyroidism? It's also called thyrotoxicosis. It's a disorder caused by excessive delivery of the thyroid hormone. So you've got too much to the peripheral tissues, because the primary effect of the thyroid hormone is to increase metabolism and protein synthesis. Hyperthyroidism affects all major organs. So you've got too much. So what's the pathophysiology? The effects of hyperthyroidism are the result of increased circulating levels of thyroid hormone. This hormonal excess increases the metabolic rate and it heightens the sympathetic nervous system physiological response to stimulation. The sensitizing effect of abnormally elevated thyroid levels increase the cardiac rate and stroke volume. So when you do your assessment, you may see a patient that has an elevated heart rate. And one of the medicines that's common for thyroid disease is Lavoxil or Zenthroid. That is the most common. And you can read about these in your med-surg book under the thyroid chapter in your ATI med-surg book. It talks about some of the medications there for hypo and hyperthyroidism, and I do want to refer you to that ATI med-surg book to review some of those meds there as well. It also affects every system. Look at page 863. You can have a goiter around your thyroid gland, shortness of breath, nausea, vomiting, diarrhea, abdominal pain, muscle wasting, loss of strength, and fatigue. And the fatigue is really evident. These people have just no energy. Hand and eye tremors is very common. You can't sleep at night. Your emotions are unstable. You have a lot of restlessness, anxiety, blurred vision, photophobia. You have what's called Graves' disease, and I want you to read Graves' disease on your own. But with Graves' disease, this is where you see the goiter, and then you have the bulging eyes. Look on page 862, and you'll see a picture, and I also have one on the slide here as well. So what's the etiology? Hyperthyroidism results from many different factors, including autoimmune stimulation, as in Graves' disease, excess secretion of thyroid-stimulating hormone by the pituitary gland, thyroiditis, neoplasms, and toxic multinodular goiter, and an excess intake of thyroid medications. The most common etiologies of hyperthyroidism are Graves' disease and toxic multinodular goiter. So you can have Graves' disease and have this goiter, and it can make the thyroid disease even worse. The risk factors: women are at increased risk for hyperthyroidism, 8 times more likely than men. Genetic factors such as family history of Graves' disease also contribute to the risk, and other risk factors are being age 20 to 40 years of age, with an increased iodine intake. So they may monitor you and ask you, what is your intake of certain types of foods, so they can see what type of or how much intake of iodine you're taking in. Got a little YouTube video here, so make sure to watch it. It is on hyperthyroidism. I may not have time to show it in class because we have a lot to cover that day. Prevention: hyperthyroidism caused by Graves' disease is a genetic condition that cannot be prevented. Individuals who smoke are more likely to develop hyperthyroidism. Based on this data, individuals with a family history of disorder should be educated about their increased risk and encouraged not to smoke. And here's a picture, and the one on page 862 is really good as well. And you see the bulging eyes. And with the bulging eyes, this is called ophthalmosis, and it results from an accumulation of inflammation byproducts in the orbital areas, and the sclera is visible above the iris. So you just have a big bulging eye. The clinical manifestations: the patient with hyperthyroidism typically has an increased appetite, yet loses weight, and may have hypermotile bowels or hyperactive peristalsis, bloating and pain, and diarrhea, or like a dumping syndrome. Additional manifestations related to hypermetabolism include heat intolerance, insomnia, palpitations, and increased sweating, because it's a hormone and it does affect your heart rate. The skin is smooth and warm. The hair may become fine, and hair loss can develop, and you may have like very thin and bald spots on your scalp. You may lose hair over the eyebrow, in your axillary area, your pubic area. All these are the most common. Emotional lability is also common. So look again on page 863 and look at the systemic effects. It affects every part of our body, and it lists all of these there for you. Treatment of hyperthyroidism focuses on reducing the production of thyroid hormone by the thyroid gland, thus establishing a euthyroid or normal thyroid state, and preventing or treating complications. Depending on the patient's age and physical status, medications, RAI therapy, or surgery may be used. And the RAI is that radioactive iodine isotope. And what they'll do is they'll go in and they'll kind of kill off the thyroid so it'll quit making overproduction of thyroid, and then you have to be on medicine to make sure you're getting the proper amount. Again, read over Graves' disease and make sure that you understand the term goiter and ptosis, which is a forward displacement. It's protosis. It's a forward displacement of the eye. Protosis. Okay. Again, with hyperthyroidism, You may have a toxic multinodular goiter. It's a thyroid tumor characterized by small, discrete, independently functioning nodules in the thyroid gland that secrete excessive amounts of thyroid hormone. Despite elevated levels, the resulting manifestations of hyperthyroidism develop slowly. And so, even though you've got an abnormality, it may not happen overnight, okay? An excess of TSH stimulation, and TSH is one of the thyroid stimulating hormones. That's what it means, thyroid stimulating hormone. Overproduction of the TSH by the pituitary usually stimulates the thyroid gland to produce excess. The elevation in the TSH secretion often results from a pituitary adenoma. This secondary form of hyperthyroidism is rare. Thyroiditis. So what is that? Inflammation of the thyroid gland most often is a result of a viral infection of the thyroid gland. The symptoms of thyroiditis are acute inflammation and effects of increased thyroid hormone. Thyroiditis is an acute disorder that may become chronic. It may result in a hypothyroid state as repeated infections destroy the thyroid gland. And then thyroid storm or thyroid crisis is an extreme state of hyperthyroidism. It's rare because of improved diagnoses and treatment methods today. If it does occur, those affected usually are individuals with untreated hyperthyroidism, most often Graves' disease, or individuals with hyperthyroidism who have experienced a stress, infection, trauma, untreated diabetic ketoacidosis, and that's what DKA means, or manipulation of the thyroid gland during surgery. The rapid increase in metabolic rate results from the excess thyroid hormone causes the manifestations of thyroid storm. And you may see a body temperature of 102 to 106, tachycardia, systolic hypertension, GI symptoms, abdominal pain, vomiting, diarrhea, confusion, psychosis, delirium, and seizures. This is a medical emergency, and you have to have rapid treatment, and the physician needs to be notified ASAP. Collaboration, the focus of care of the patient with hyperthyroidism is on preventing complications until the thyroid levels can be brought down to normal. And then some of the diagnostic tests, these are listed here for you. I want you to read over these and just be familiar. Some of the most familiar is the TSH, the T3, and the T4. And when some people have to have what's called like the antibody test, and because in hypothyroidism you still have the thyroid hormone. It's just kind of floating around there, not doing nothing. We'll talk about that in a minute. Here's your lab levels on H65 for your TA, your TSH, your T4, your T3, and your T3 uptake, and then thyroid suppression. And I can hear you now. Do we need to know that? Yeah, you do need to know your TSH and T3 and T4. Those are the most common. Pharmacological therapy, again, they didn't really list any medicines in here, but they are anti-thyroid medications, and I want to refer you to your thyroid section in your ATI Med-Surg book. Please read over that. It does list some medicines in there. To rapidly decrease the cardiovascular symptoms associated with hyperthyroidism, they'll put you on a beta blocker, such as Inderol, to help control your heart rate. The radioactive iodine therapy, it concentrates in the thyroid. It damages or destroys the thyroid cells, so they produce less thyroid hormones. You may see results in 6 to 8 weeks. The patient's usually not in the hospital, doesn't require radiation precautions. It is contraindicated for pregnant women. Patient may develop hypothyroidism and require lifelong thyroid replacement. Adverse reactions are thyroiditis, which is inflammation, and cardiac instability. And then some of the other options are surgery and thyroidectomy, removing all or part of the gland, is indicated. And several years ago, I experienced this. I have what we're going to talk about in a minute called Hashimoto's disease, and my thyroid attacked itself. It shut it down, and I went through all kinds of issues and ended up I had a goiter, and I had to get my thyroid taken out, and I've been on replacement medicine for probably 15 years now. It really will change your life. I've never experienced anything, the weight gain, the dry skin, hair loss, emotional instability. It is all true what they have written in this book because I have lived it. Children, I want you to just read over that. I'm not going to say anything. You can read over that. And again, it's contraindicated in women, some of the treatments, the radioactive iodine. Please read over pregnant women as well. And then lifespan considerations, because I don't want this presentation to be long. Make sure you read over that as well. The nursing process, you want to observe for manifestations of hyperthyroidism. Ask about, does any family have it? Weight loss, are you on thyroid medicines? Are you having issues with your menstrual cycle, because it will alter your menstrual cycle? And any bowel and abdominal issues. You want to look at all of these when you observe and do your patient interview, and evaluate muscle strength, tremors. I know when I hold my hands out, my hands used to tremble really bad, but mine are pretty controlled now with my medication. You want to assess the eyes. You want to feel for the goiter. You stand behind the patient and you press on one side and you have them swallow. And if they have a goiter, it'll come forward and you're able to feel that. The doctor always did that every time I went. And they would lay me on the bed and put a pillow up under my shoulders so my neck was extended, and he would palpate all around my neck to feel the goiter. Nursing diagnoses, these are listed here, and as you see, nutrition and cardiac are some very pertinent ones. The goal is to improve the patient's situation, and how do we do that? We want to monitor cardiac output, make sure they're on the right medications, and encourage frequent rest periods, limit activity, and have them report if the symptoms, the tachycardia and arrhythmias and congestive heart failure, if all that becomes worse. Look, jugular vein distension, that needs to be reported. Visual health, tinted glass shields, artificial tears because you have photophobia, you're very light sensitive to the light. Cool, moist compresses. Tape eyelids shut at night if they don't close. From the Graves' disease, some people are not able to close their eyes. Keep the head of the bed elevated 45 degrees and tell the patient to report pain and vision changes. Balanced diet, high protein, high carbs, in between meal snacks, 6 small meals a day, better than 2 large meals, and you want to increase the caloric intake to about 4,000. And then body image, nobody wants to lose their hair, nobody wants to be underweight, where they look frail, and so we need to encourage them, to have that they're doing everything that they can, okay? And then of course evaluation that they have normal thyroid function, normal intake, their cardiac is normal, and they're taking their meds. So that's hyperthyroidism. Hypothyroidism is the opposite. And if you look on page 869, it shows you the system effects of hypothyroidism. And one of the biggest things here is the thyroid's not working well, and so you're not able to burn up, your metabolism lowers, and you gain weight. When my first went out of whack, I gained 60 pounds in like 6 months, and I was devastated. And all my physician would say is, well, you need to watch your diet. I was hardly eating anything, and the weight just kept coming and coming because my metabolism was not working, because my thyroid was not working. So what is hypothyroidism? The hypothyroid state in adults is sometimes called myxedema. And you see a picture here of how people can look. And we'll talk about some of this. The term reflects the characteristic accumulation of non-pitted edema in the connective tissues throughout the body. The edema is the result of water retention in mucoprotein deposits in the interstitial spaces. The face of a patient with myxedema appears puffy, the tongue is enlarged, and the voice is hoarse and husky. And I went through all of that. And I experienced a lot of that. Fortunately for me, I've been able over the last year to lose 30 pounds, and it has not been easy because, like I said, I've been dealing with this for 15 years. And so you have this accumulation of fluid in the interstitial space because your thyroid is not working. It's not burning up these calories. And sometimes these patients don't hardly eat anything and they still continue to gain weight. So what are the primary causes? Congenital defects in the gland, loss of thyroid tissue following treatment of hyperthyroidism, anti-thyroid medications, thyroiditis, which is inflammation, and they think that was my issue, constant just inflammation to my thyroid gland, and iodine deficiencies. And then the secondary results from pituitary TSH deficiency or peripheral resistance to thyroid hormone. Medications can cause it, and the cardiac drug amiodarone, which contains 75 milligrams of iodine per 200 milligram tablets, is increasingly being implicated in causing thyroid problems. Steroids, lithium, phenytoin, which is seizure, propranolol, which is for blood pressure and heart rate, and they list several things here on 868. I would pay attention to that. Risk factors. Anyone can develop hypothyroidism. However, it is more common among women older than 50 years of age. I was 41. Individuals who have lost a close relative, it is a genetic disorder. And then there are other factors such as iodine deficiency, and then there's Hashimoto's thyroiditis, and that's what I had. That's the most common cause of the goiter and primary hypothyroidism. And there's a family link, and I do have family members that have this condition as well, and family members with diabetes. So since I've had Hashimoto's, I have had issues with my blood sugar as well. Hashimoto's thyroiditis is the most common cause of goiter and primary hypothyroidism in adults and children. In this autoimmune disorder, antibodies develop that destroy the thyroid tissue. Functional thyroid tissue is replaced with fibrous tissue, and the TH levels decrease. Decreasing levels of thyroid hormone during the early stages of the disease prompt the gland to enlarge in an attempt to compensate, causing a goiter. As the disease progresses, the thyroid gland becomes smaller. This disorder is more common in women than in men, and with a family link. And some of the reason they think it's more common in women is because we go through menopause and our hormones change during menopause. Here is a video. Please watch it. It's fairly short. May not have time to show it in class that day. Prevention. There's no prevention in developed countries. Diets contain adequate iodine. In countries where iodine deficiency is common, then it could be an iron deficiency problem of iodine in those countries. Hypothyroidism clinical manifestations. The onset is slow, appearing over months. I probably dealt with mine for about a year and a half before they were able to diagnose me. I had the fluid retention, the edema, and I still have some of that in my feet. Decreased appetite, but gaining weight. And of course, constipation because you're not eating like you're supposed to. And it slows your peristalsis down as well. Your skin is very dry, it's very itchy, it's scaly. You have shortness of breath from the fatigue, pallor, hoarseness because your goiter is in the way. Mine displaced my windpipe, and I was having trouble swallowing and breathing. Muscle stiffness is unbearable. Sometimes you literally go to bed and wake up with very sore muscles. It's almost like having a bout of fibromyalgia as well. Decreased senses of taste and smell. It does affect your menstrual cycle and it will knock it off balance. You can have anemia and you can have an enlarged heart. And you also have elevated lipids as well. And I could have wrote this chapter because I have lived all of this. What is a myxedema coma? This is a life-threatening complication if from untreated hypothyroidism. You end up with severe metabolic disorder, hypothermia, shallow edema, especially around the hands, eyes, and feet, cardiac collapse, impaired mentation, and coma. The treatment of myxedema coma addresses the precipitating factors and manifestations and involves maintaining a patent airway, adequate fluid, electrolyte, and acid-base balance, maintaining cardiovascular status, increasing body temperature because your body temperature will drop. And on page 870, it shows your labs, your TSH, T4, and T3 and T3 uptake for hypothyroidism. And it also shows clinical manifestations on the bottom of 870. I would look over that. Clinical manifestations for myxedema coma. Again, these are listed here for you, and there is the treatment, and I just talked about that. Collaboration. Some of the medicines you want to collaborate with the pharmacy, and these are in your ATI MedSurg chapter as well on thyroid or hypothyroidism. But the treatment of choice is levothyroxine or Zenthroid. Levothyroxine is the generic brand of Zenthroid, and that's what I take. I take Lavoxil, which is the generic brand. Let me re-say that. You have Zenthroid and you have levothyroxine. Lavoxil is the generic of levothyroxine, not Zenthroid. Let me correct myself on that. Some people are allergic to Zenthroid and they're not able to take Zenthroid, and that's why they end up on the levothyroxine. That's what I've taken the whole time. And it has to be adjusted. I take 125 milligrams every day. I thought I would be smart one time, and I went without it for 2 weeks, and my levels bottomed, and I was as sick as I could be, and I will never do that again. I cannot live without it. I don't have a thyroid. I had to have mine removed. It's completely gone. And so, once your thyroid goes out and it's not producing the hormones, the TSH and all of that, you have to have a supplement or you will not survive. You have to have that. And that's kind of scary. Please read over the children. I'm not going to speak to that, and the pregnant women as well. As you see here, for pregnant women, it can cause preeclampsia, anemia, miscarriage, so it can have some adverse effects in pregnant women, make them more fatigued and stuff. In the older adult, and you do see it more in the older adult, they're at risk for age-related changes such as atrophy of the thyroid gland and having the nodular goiter. Treatment is conservative, and usually it's based on your symptoms. You can start levothyroxine at 50, and it can go up to as much as 400. Mine is in micrograms, so I take 125 micrograms a day. But please refer to your ATI MedSurg for that as well. The nursing process, we want to observe for clinical manifestations. When did it happen? What are your symptoms? Look at the neck. What is their diet? Do you use iodized salt? If you buy salt from the store, then it's iodized. Muscle strength, the deep tendon reflexes, cardiovascular. You see, thyroid affects every body system, and so you have to do a thorough head-to-toe assessment, because you will have palpitations, you will have fatigue, you will have the dry skin, the weight gain, the mental confusion. You'll have all of that. especially as it gets worse. Decreased cardiac output, constipation, impaired skin integrity, and these are just a few. Of course, here's our plan. Make sure you read over the plan, and then the implementation. We want to make sure we monitor the blood pressure, the rate and rhythm of the apical and peripheral pulses. And when you do your head-to-toe assessment on your patient, have them hold their hands out and see if they've got tremors. And every 6 months, I have to go get blood work. And so they check my thyroid levels every 6 months and adjust my medicines according to my levels. I function better if my thyroid levels are a little higher. Because I've been dealing with this for so long, so I need a little more to give me a little more energy. I can tell when my thyroid levels drop because my tongue gets thick and it gets beefy red, and I feel like I am drained. I just feel like death warmed over. I feel so weak and fatigued. And so these people really need to go to the doctor on a routine basis. Suggest that the patient avoid becoming chilled, because sometimes they can have effects of cold. And do a good cardiac assessment. Constipation, tell them to increase their fluid intake and fiber and increase activity. Maintain skin integrity, turn and reposition, use lotion, pillows for support, range of motion exercises, baths only as needed because of the drying of the skin, and you want to use alcohol-free soaps and anything to avoid drying the skin even more. And then, of course, we want our vital signs to remain normal, our cardiac normal, our skin remains intact, no edema, our vision is good, our elimination patterns are good. If the outcomes are not met, we need to modify and look at, did we do everything that we could do for the plan? Thank you.